So I'm going to be talking more about the post-operative management after lumbar fusion, and mainly because I didn't know much about this. Most of the research is mostly with microdiscectomy patients. And when you do look at lumbar fusions, it's amazing that when you look at them, it's mainly things that we are doing in the hospital that's in the protocols, how they get in and out of bed, walking, and finally getting up and downstairs. So in other words, just enough to get them out of the hospital. But the things we don't discuss, the important things like return to work and activity, and most protocols are very poorly defined. So in terms of the literature, these are a couple of studies. One in the military medicine, they looked at 232 active duty servicemen. These were elective surgeries. They were either a decompression with or without fusion. 64% returned to activity. And again, results were the same whether they had a decompression with or without fusion. In terms of workers' comp patients, 76% did not return to work. So the question always is why are these people not doing the same, and what's happening? We do know in workers' comp there's usually a prolonged time off of work, as well as even a psychiatric history that can lead to this. So Madeira in 2017, I thought, here it is, this is my whole talk, went over all the literature for lumbar fusion rehab. And they looked at over 1,850 articles and came down to 21 of them that were level 1 or level 2 studies in regards to lumbar fusion rehab. They graded the evidence whether it was good, fair, or poor, or inconclusive. So in terms of the recommendations for lumbar fusion, their number one recommended, or the one with the best evidence, education. Preparing the patient both physically and mentally for surgery, but also setting realistic expectations for surgery, and that's just very important. So you will see that Colleen Stalock, along with Dr. Dixon's group, they now have a pre-spinal surgery class, and they're doing this again well in advance of surgery, not only to prepare them and let them know about the surgery, but also do some early exercise. But here's the one that kind of surprised me, the psychosocial testing. And again, there appears to be almost a growing appreciation for this portion. In fact, one of the journals I wanted to get, JOSPT, but it's May's journal, is actually looking at more or less the behavioral type of treatment for distressed chronic low back patients. They're actually seeing more and more of the psychosocial testing. So in Abbott, in his study group, anxiety and depression related mental health disorders, we're seeing again a large majority of these patients. Kristen Archer, a physical therapist, in her group of 120 spinal surgery patients, depressive symptoms seen pre and post-op were very predictive of increased disability. And we know from several references that depression is a very powerful indicator of poor outcomes with fusion surgery. So here came the fear avoidance model, and this came out, of course, when I was just out of school, so I knew too much, so I didn't study it much. But the fear avoidance model, very simply, is when we have pain, we have two pathways. If it is considered non-threatening, we get on with normal activity, it's uneventful, and we recover. The other pathway, if the pain is threatening. And if it's threatening type pain, we have anxiety, we develop this pain-related fear, and finally these maladaptive behaviors, or these fear avoidance behaviors. Physical activity declines, disability increases, depression. And this again is a theory, but you're seeing this now in even some of the newer studies that it's being validated. So Waddell in 1993 came out with the FABQ, or the Fear Avoidance Belief Questionnaire, to identify these patients with fear avoidance behaviors. And there's many of these questionnaires out there now. They did a study in 2010, PT, and basically asked PTs to identify patients through their clinical exam and direct observation if they can identify these people with fear avoidance behaviors. And no, they don't do a real good job of it. As physical therapists, we always tend to measure function, but are we actually looking at these type of questionnaires where we look at fear avoidance behaviors? So this tends to be more and more important in the rehab. A couple of other things with the psychosocial portion. In this study, patients, again, who have this longer pain and become more deconditioned, again, don't recover as well as those that are in shape and have pain not quite as long. In a couple of studies here, Abbott and Christensen found in these fear avoidance behavior type of patients that the psychomotor therapy actually did better than traditional physical therapy. So something to consider with rehab, especially those people who are not progressing very well. In terms of aerobic exercise, again, other post-surgical type of populations, walking again has done very well in terms of decreasing rate of post-op complications. Pre-rehab and lumbar fusion surgery, these patients reached their milestones earlier. Also, length of stay was decreased. This is very small. You don't need to really look at this. This is in the protocol in your jump drive on the fusion protocol, but we always tell patients we want to have them walk. And then they ask you how far. And then we'll tell them and they go, how far is that? And then they'll say, well, gee, what if I walked into my block? How far is that? Well, this protocol set up for walking is more with the Fitbit. You know, it seems like everybody has Fitbits now. So it actually has to do with steps, and it's broken down for those older patients, younger patients, ones not quite in shape, and ones that are advancing very well. So this is in the protocol, and again, thanks to Beth Perkins from the University of Mary who helped with that. In terms of strengthening, these people are already weak. We know from studies that when they've tested them, they're very weak in their extensor musculature. Dr. Moore, who previously was with the Bone and Joint Clinic, used to show me MRIs of chronic low back patients. And the paraspinals are supposed to look nice and lean like a sirloin, but with this chronic back pain, it starts to get this fatty infiltration. So you're seeing this weakness and this almost breakdown in the muscle. Also, we know the adverse effects of some of the lumbar fusion surgeries. There's a lot of dissection, and for up to 3 months, we'll see loss of strength. Active rehab, though, has been shown to help with this. So again, many of the studies are showing both short and long-term effects with this rehab. Some of the rehab they're going to talk about is these neutral spine exercises. And I'm going to briefly go over this. Miranda, in her core talk, will talk a little bit more on this. Early exercise also has not been shown to hurt the hardware. In fact, PT Journal back 15 years ago investigated this and is actually walking that puts more stress on the hardware versus these exercises. In terms of the muscle groups, the multifidus and transverse abdominis, Miranda, though, will go over exercises that she says give you more bang for the buck, so she'll go over that. But this was a study I just wanted to point out that they actually used in this research paper in regards to the neutral spine program, and I'm going to show it to you. Some of them are good, some of them are questionable, but again, they hit the abdominal group as well as the back extensor group. So for the abdominal group, they did shoulder extension. They actually used a cable machine, but you could actually do this with TheraBands. So just the straight elbow row activity. They also did the shoulder horizontal abduction. This is done in sitting. And then finally, a hip extension activity, unilateral. So that was more for the abdominal group. For the back group, they did shoulder flexion. And again, easily done with TheraBands or weights. However, this one was questionable. This one was a Roman chair exercise. And I don't know if I would put any of my back fusion patients in this patient, so I'm just pointing this out. But this is one of the ones they were listing as a neutral spine exercise. In terms of other recommendations, soft tissue mobilization, inconclusive. This is more massage type activities. Nerve mobilizations, which are in a lot of protocols to help keep the nerves from adhering down, inconclusive. And then joint mobilization. Again, we don't mobilize the surgery, but now they're looking at mobilizing those joints above and below the fusion. The other part I found interesting was timing and duration. Ostergaard actually did 2 publications here in which the original thesis was that if we started rehab earlier, these patients got a head start and did better. Well, they actually found just the opposite in terms of strengthening, where those who started at 12 weeks versus 6 weeks did up to 4 times better with pain and functional mobility. So what they are saying is starting with walking early and those type of things, but in terms of a very aggressive active rehab program, it's probably better to wait. So in conclusion, again, education, very important. We are starting that now, but also the coping strategies. And again, as therapists, we need to identify those patients who have those fear avoidance behaviors. And if you can do those very early in your rehab, it will help you in the long run. And then finally, a good walking program. In terms of starting a therapy, we're starting 2 to 3 months post-surgery versus any earlier. Thank you.